And we're back, and we're getting ready to start our conversation for this morning with Director of Health Services in the Ministry of Health, Dr. Marvin Manzanero. Good morning.
Good morning, Doc.
Morning, and thanks for the invitation again.
Well, I know the Ministry of Health is dispersing its team today across all media to be able to ensure that people are up to date with the latest information on COVID-19.
Yeah, and actually this is, I think, the third time we have come to this show to discuss the topic. I went back to our notes and I was here 5 or 6 weeks ago.
Yes.
Yeah.
And I think 5 or 6 weeks ago we did say it's not a matter of if but when, and I think it's getting closer, and as there might be some thoughts of whether it's even circulating. That's going to always be a difficult task. I think trying to find your index case is always going to be the challenge for any health system.
Index as in the first person?
Index in the first person that potentially comes into any country.
Okay. You know, it's interesting because, in fact, the CDC and the representatives in the U.S. government said the very same statement last week, Thursday, I believe, that it's not a matter of if, it's when, for them to have an outbreak in the United States. And just over the course of the weekend, we've seen many new cases. This is of importance to us, especially because of the travel patterns that people have into the country. How does this change the context for us here?
Well, you know, travel bans are not routinely recommended by any public health system. And yesterday at the CARICOM meeting, virtual participation we had, that was again reinstated by PAHO, by CARFA as lead agencies in the region, that they are not recommending, and nor have they ever really recommended, at least not for COVID-19, any travel ban. I think CDC does that. And yesterday, Belize was one of the countries listed that has a travel ban, in our case for China. But again, when you go back and look at the data, China has had declining rates.
Yeah.
And it actually started 1 month ago. February 2nd is when they started to decrease significantly. So even that has to be considered for our context, whether that needs to be lifted. We did issue travel recommendations to other countries that had ongoing transmission, Italy, Singapore, South Korea, Japan, Taiwan, Iran. But even when you look at that, the US now seems to be having levels of what we would say community transmission, which means...
What does that mean?
Community transmission means that you already have one case and it's already starting to spread beyond the contacts that you have been able to establish or contacts that you're being able to track.
Which means they got it in their community versus having traveled outside of the country?
Yeah, and the person doesn't have any travel history or contacts with anybody who has been... so again, once you start going back into the data, you will realize that they are saying themselves that it could have been in some communities before they actually identified any given case. The same thing is happening in Italy, where they are saying, well, perhaps they have had it weeks before they actually identified the outbreak in the northern part of Italy, and that's why they seem to have a higher mortality than other places. But then it could be that they have much more cases and they're just finding out and identifying those. So that's where I think it becomes critical, because once you identify your first case, if you're able to do that, then you have to go and track and monitor all those.
Let me ask a question here, Doc. Fortunately for us at this point, we haven't had a case to report on or an outbreak. Cross our fingers. However, what we've been noticing is that because of social media, there seems to be a heightened sense of panic, if I may, based on persons putting false reports out there of COVID-19 being present in Belize. How does the ministry, or how does any health authority mitigate or combat against all these erroneous and baseless stories that are put out there?
You know, that's a very difficult situation. I think it's it can be responsible if it's fueled by media. Social media is difficult to control, but any person who's doing that is actually being very responsible for a variety of reasons. There's 3 things that are going to make it more difficult for any successful surveillance intervention. One is fear. And it's okay that people are fearful, because it usually is as a result of the unknown,
Yes.
or when reading false information. When people just read headlines from different stories, then and you don't get down to the bottom of it, if you don't read the entire article, for
Yeah.
example, then you are going to be fearful. When in doubt, you always have to consult your local provider and find out what's going to happen. Two is rumors. That doesn't help anybody, because what we are doing is we have to follow all those rumors. Just last night there was a big rumor on a social media platform, which was followed. Didn't result into anything, but it drains your human resources. It drains,
because you have to investigate each one.
Yeah, and
So
it
if
drains.
I call and say the people next to me might have COVID-19, you will.
We have to go and find out. Do your clinical investigation. Be rushing out there. I mean, for the last 6 weekends, I think we have been following all those situations. Sunday we had doctors going to the western border, for example, and there's a delay in being able to get a doctor out there, because you also have your usual health settings that you have to be taking care of. I think the third item that kind of makes it difficult for a surveillance intervention is stigma. Of course, now we're noticing that it's no longer related to China, so I don't know that the stigma towards the Asian community is going to be there. But those three elements can turn down your surveillance system, because what will also happen, or what can potentially happen, is when people feel that they may be ill, they were in contact with somebody, or they knew somebody, and they are feeling that they are going to be stigmatized, or the entire community is going to turn around them, then these people are going to go into hiding. And I think we have seen it with other epidemics. HIV, we still have that stigma of people going to hiding, and that makes it more difficult, because then you're not forthcoming with your information. If you're landing at an airport and you know that you're being linked to anybody in Italy, and if you're coming from Italy or anywhere near, you're not going to say. You might say, I'm coming from X place, and makes it more difficult. So I think people just need to we need to be very cautious. We need to be looking at official sources of information, and understand that the interest of the public health system is ensuring that the safety and health well-being of everybody is kept. But we can't do that if we are doing it in a solidarity kind of way.
Well, and I think, for years we've heard that a flu pandemic, we're well timed for a flu pandemic. And I think when people hear of a new virus coming out, there's a natural fear that takes over. I think you're absolutely right in the fact that sometimes people don't read the details, and they kind of just look at numbers grow and extensive coverage. But what also helps is a free flow of information. And that's why we're grateful that you're here this morning. Let's take a look, because we have to talk about what systems are in place for when we do detect the first case. As you keep on saying, it's not a matter of if, it's a matter of when. It's been 2 months since the new virus was identified. What do we know so far about who it affects, how it affects them? What's the mortality rate? In other words, how many people actually die from it?
Okay, there's an evolving situation, but now I think we have more information than what we had a month ago when we were here. One is mortality rates will fluctuate. So when you do an average, it's a little bit under 3, which in any given flu season anywhere else, Mexico had reported earlier that they were having a 4% mortality rate.
For flu?
For flu, other influenza viruses. What we're noticing with COVID-19 is that it seems to be affecting the older population. So that means it's more likely to be a more aggressive form if you have diabetes, if you have hypertension. It's been linked to obesity. Of course, if you're a smoker, then you have a higher probability of getting a complication. If you have HIV, cancer, any disease that is altering your immune system. So in those, because you're being asked, okay, what are you going to do with this specific population? Then the specific population needs to make sure that they are taking all their medications as prescribed, making sure that everything is...
get your diabetes and your hypertension under control.
Yeah, trying to do the usual things that we have been saying: eat healthy, drink healthy, rest well, do exercise, and make sure everything is under control. Make sure you're following up regularly with your healthcare provider, as you would with any other flu situation. We had said at the beginning of the flu season, in the middle of the flu season, we keep saying that those are the people who should have gotten a flu shot. Not just for COVID-19, because there is no protection for that right now, but in general, because you're more likely to have a complication as a result of the flu. The mortality rate is higher in those 80 years plus.
Yeah.
As you go down, the mortality rate is around 0.4%, 0.3% in younger, healthier adults.
Yeah.
So it follows the same pattern as others.
Has there been any change in looking at what happens in other ethnicities, for example? Because we know the preliminary data was out of China, where the median age for hospitalization, I think, was somewhere over 50, and death was about 70 and 80. Since it's now in places like Italy, for example, or in Iran, is there any difference in terms of your ethnic background?
It doesn't seem to be the case.
Okay.
I know we're talking about older age groups, but then you also have to look at the dynamics of populations.
Yeah.
European populations are, on average, older populations than, for example, what we have in Belize.
Yeah.
So that in that. The other thing is it's not airborne, which is a common concern, which means it's not out floating in the air. It's going to be transmitted in the same way other flu viruses, which means usually hand.
Contact.
That's why the importance of washing our hands continuously.
Yeah.
I mean that we can't overemphasize that. It's in your hand, it can survive up to 48 hours on average as other flu viruses if you are not doing proper hand washing. If it's in the surface, it can last, in your hand it can be 3 hours, in surface it can be up to 48 hours. So that's why door handles, you know, the usual things that people are touching, that we're the railings of public offices, those are wherever you're touching your hand, and that goes to your face. But then the other mechanisms that we really seem to not be aware of, the phone. I mean, the phone is a lethal situation. It has 10 times more bacteria than your toilet seat, for example. Of course, it doesn't have the same bacteria necessarily, but how many of us go to the bathroom with the phone? And the phone is there, and you're really just touching your face with your phone. So at the end of the day, it's going to be
It's not something we want to think about, but it is important.
But it is.
Yeah.
And how many of us clean the surface?
Yeah.
And then the handshaking, those kinds of things. Is those common day-to-day habits that we have?
So currency would also be one of them, right?
Currency is one.
Yeah.
Even people who wear glasses, I mean, you're more likely to be touching your face, and then that becomes the same issue with the mask. People who are not traditionally wearing a mask.
Let's jump into the mask conversations, because that's one of the things the public has been asking. Where can they get masks? When they should start using masks? But in fact, the WHO, the CDC, several other major health organizations have advised against healthy people using masks. Why is that?
Because one is it's not proven to work.
Yeah.
I mean, it's not going to protect you. For people who are not used to wearing a mask, that becomes a foreign object. So it's more than likely that you're going to be trying to fix the mask around your face. You're more likely to be contaminating that.
Yeah.
And then if you're not changing the mask frequently, then that becomes a petri dish, if you will, for other microbes in there. So it's not routinely recommended.
And your eyes are still exposed, which
your
is
eyes are
open.
still exposed, which is where an entry point can be. So the municipality is not going to be procuring masks for the general public. That's not the way it works. We are not recommending anybody, nor is any other public health entity anywhere in the world recommending for masks to be worn by a healthy individual. Who should wear a mask, if any? Well, the healthcare workers, and we are going to make provisions for ensuring that they have their PPEs, their masks that are needed in that regard, because they're in contact with patients, not only COVID-19 in general.
Yeah.
If you're ill, then you may wear a mask in the sense that it's going to protect you from sneezing, coughing, the droplets that you exchange when you're talking, for example. Then you are minimizing the risk of spread to others. That's the only person who should really
be wearing a mask if you're sick.
If you're
not
sick.
if you're healthy.
Yeah, but if you, again, the recommendation is if you're sick, you should really be confined to a specific area so to avoid spreading the virus.
I think the misconception is persons wear masks because they figure the virus is airborne. I think probably that's...
It isn't. I mean, the virus is
airborne, but
it's around in
it's
places.
the misconception that people would have as to why they would wear a mask, because they're thinking perhaps they're breathing it in.
No, again, I think we had said it a year ago, because it's, why are you having so many of, in the China, the cities that you're seeing, people wearing masks? But we had said they are traditionally wearing that because of the smog
Pollution.
and other,
Yeah.
not related to COVID-19.
Yeah.
We probably are not looking at it from that angle, but
Yeah.
that's one of the reasons.
Yeah. And also, I think people feel helpless. They want to do something actively to protect themselves. And for some reason, hand washing messaging doesn't resonate to the same way they feel when they wear a mask. Now, I'm not saying it's right. I'm just saying, you know, when you
just the
see, when you're
behavior.
in the face of something unknown, you have to feel actively, like you're actively participating.
False sense of security is
Yeah.
also a reason why a mask is not, because you can let your guard down
Yeah.
more easily. Which is the same thing with travel bans. You know, travel bans are not routinely recommended because you might think that because it's a travel ban, you have a false sense of security. But
That
then
everything is safe.
it's, I mean, in an airport, for example, you might have somebody, let's say you do ban for all these 6 countries, but you have a Belizean who's coming from where, like, and the country
Cancun.
doesn't have, from Jamaica, and you run into somebody at
Yeah.
the airport in Miami, shake hands, he was coming from
Yeah.
Italy, going somewhere else. Arrives, you shake up everybody's hand when you're at the airport, and that's it. I mean,
Yeah.
that is the mechanism. So travel bans are not
Should we
necessarily
move
going to
away from handshaking right now? I know, like in Italy, they're advised, because they usually kiss in greetings, they're advising them not to do that.
There's also layers of responsibility, because I think for us, the way it's going to work, and in discussion with our counterparts, is do like the hurricane kind of situation, the green, the yellow flag, the red flag.
Yeah.
We don't have an imported case, which is where I think it's going to eventually pop up, if it isn't perhaps circulating in society already. Until we are managed to identify a transmission that's ongoing in a given community, I don't think we're going to go down that road. But I mean, we're thinking and foreseeing, because we've been asked about, okay, what about massive events where people congregate? Ruta Maya being the next one. I don't think there's any situation right now to say, okay, that needs to stop it.
But if
The
there is a
usual
confirmed
mechanisms.
case between now and then, is there going to be a change in looking at mass public events?
No, we have already thought of it, and we have alerted NEMO of the potential
Okay.
situations. The events around Easter, the Agric show, those are going to be looked at, and people have been placed on alert just if there's a potential situation.
So you are collaborating with NEMO as a part of your preparation. I have a question with the Ministry of Education, because I think parents are especially scared. I know with the flu season, I saw some schools actually send out advisories to parents saying, if your child is sick, please keep them home.
Yeah, well, before we get to NEMO and Ministry of Education, who has been around the table from the beginning from us was Airport Authority for that particular situation there, border management for the borders, including San
Immigration,
Pedro,
right?
the ship agencies in terms of cruise ships, immigration, of course, BTIA, because it has implications, Tourism Industry Association, BTB, Belize Tourism Board, so much so that they have participated in the meetings that we went to initially, and Ministry of Tourism. We have sent out a memo last week to Ministry of Education highlighting what you need to do at your local level in terms of making sure you're getting adequate information. Keep stressing the mechanisms of prevention with your school students and staff. If your student is ill, then you have to keep them home. And we also place in that note to CEO of Education that we have to be mindful of the fact that if there's an ongoing transmission, there might have to be changes in terms of closure of schools, school calendars being shifted around, as has happened in other places. So that has gone out in that regard. NEMO participated in our first meeting. We have been in discussions with the NEMO person in charge in Belmopan from the middle of last week on almost every day now. They have said that Ministry of Health will lead. They will back up all the support. Let's say you need to put a specific area cordon off for whatever reason. You have an outbreak in a local, and then you need to want to contain the quarantine area kind of thing. They would come on board and do all that support. So we are in discussions with them in that regard, and it's going to follow the same pattern as in hurricane preparedness whenever that happens.
So you're going to have a phased approach.
Phased approach. We have multiple activities this week. We have sent a note, for example, to Social Security, the board, in terms of potential resources that we may need and how they can bridge that gap. PAHO has been at the table in that regard. We're having a meeting with Joint Security Council later on today, which includes CEOs of the key ministries outside of who we have been in discussions with. The minister and the CEO have been kept abreast of the situation. I know Minister brought the note to Cabinet last week, Tuesday, and we have asked for a supplementary budget as may be required. I think tomorrow when he goes to Cabinet, he might have a clearer sense of where the funding gaps are going to be in that regard. We have a massive event with UB on Wednesday at the campus in Belmopan, trying to educate the public. So there are activities lined up in that.
You'll forgive me for asking, Doc. For some reason, in talking to people, and I guess it becomes sort of a public sentiment, that despite the preparedness of our local health authorities, that should there be an outbreak, there is still this sort of a palpable fear that we may not be able to contain. Like that perhaps all of what we're doing is preparing, but when it does happen, we may not be able to contain and stem from spreading to other communities. For instance, if there's one in Corozal, some people feel uneasy that you may not very well be able to keep it in Corozal. I think that's one of the fears that's going around.
Yeah, but in any containment process, I said, it's your three mechanisms to prevent further spread, your three greater enemies. But understanding also this is not a Makeshift health containment strategy or win strategy, if you win. This is to be the community. I mean, how much community buy-in are you going to have? A government, all of community kind of strategy. The other thing I think very, very, because it keeps coming up, as you say, is we can't politicize this situation. And we are getting flogged and flagged on social media, on messages that get sent to us. And that doesn't help. Because you have to think that staff is on the ground. Staff is, I mean, they have been on the ground for 6 weeks through the weekends. It's a tiring process. So whenever you say things or do things to try to demoralize the work that's happening, that doesn't help anybody. So I think it will require, you're right, a strategic approach, making sure we're all saying the same thing, that people within and outside the health system need to all be ensuring that the adequate message is what is getting across.
So let's play out the scenarios, because I think people feel, or the criticism has been that they don't feel that Belize is prepared enough to deal with an outbreak. And the concern is especially in the isolation and containment. So there are two ways we can have a detection. One at an actual port of entry. The other is someone can appear at a integral clinic here in Belize City and somehow have the COVID-19. Let's talk about what happens when that first case is detected.
Well, again, and this is also, I think, part of the educational process, because people are assuming that we are going to have a COVID-19 hospital, so to speak. We are able to test and perhaps return the test in 2 or 3 hours. But we are not envisioning having a facility or a special quarantine area where all patients detected positive will go. That's not what is happening anywhere else. You have an epidemic, then that's a different situation. I mean, and then everything changes. I mean, it's like if you have
what's the difference between having some cases and an epidemic?
And I'll go to that. It's perhaps the analogy is if you use hurricanes, it's hurricane category 1 versus a category 5.
Okay.
It's a major difference. Use that analogy then. So if we find a case and you're really only having common signs and symptoms, keeping you inside a hospital might actually be detrimental for 2 reasons. One is you are more likely to infect perhaps others inside a hospital, and then more likely to cause an epidemic on a national level. But also, you being in a hospital, you are more likely to be infected with other
illnesses,
bacteria and stuff, and have a complicated case. So I think people will need to understand that mild cases are more than likely going to be quarantined at home, not in a hospital setting. And you also have to look at what the international recommendations are. Brazil made the diagnosis and that patient was sent home within 12 hours. I think the Mexican cases, they are all now at home. You just make the diagnosis. One was quarantined inside a hotel because that's where they made the diagnosis. Because people are, again, it has to do with fear. Okay, so where am I going to send my patient that's ill?
Yeah.
Really, self-isolation at home. And we have done
But what about the family members?
That's why we will have to explain and educate the family how we're going to deal with this case. Mind you, we have been doing self-quarantine, self-isolation at home with all the patients that came back or all the persons that came back from China, who people may not be aware of. I mean,
they voluntarily quarantine
voluntarily, and
themselves.
people prepared the little room, prepared the mask and everything to take care of that person at home, even though they were not ill. And we had one person who was ill but didn't have COVID-19. So that has been done and has been happening in the background.
So this is key information, because I think people are expecting a specialized wing or building or a massive military tent put up, as we see in the movies, where if a case is detected, that's where they go and they stay until they're better. But what you're actually saying is it's more likely that in Belize, if someone tests positive for COVID-19, they'll probably be sent back home, and that family will be trained on how to minimize their own transmission there. Is that what you're saying?
Yeah, because you understand also that there's no specific treatments. I'm keeping you in a hospital just to quarantine you, and yeah. Now you're talking about, okay, what happens if you have a massive event? You have.
But what if I live in an overcrowded house, or a house that isn't equipped to keep me self-quarantined?
Which is where we had talked about isolation units that we have asked facilities to identify. And I think that was taken out of context for our context, because we got criticized, okay, but you don't have the isolation facilities that the US has. We don't. And so we have to contextualize it for what we have in Belize. So for example, Carluchner has their isolation unit. It doesn't mean it has all the negative air pressure, all those things that big facilities have. Why? Because you're going to keep an area. Basically, is to prevent this patient from going into the mainstream of the hospital, and also from other things getting to this patient. Now, the critically ill patients are the ones that are envisioned to come to Carluchner. Every facility, Corozal or Njuak, would have to identify one. Now, I know the question kept, okay, what happens if you're starting to have a little cluster, a bigger group in Corozal? Then if you have to section off areas of the hospital, let's say Corozal, you have an NHI clinic and the hospital, then as I mentioned to Minister Marin just yesterday, well, we have to section off the entire NHI facility. We section it off, that no longer accessible to the general public, and we take that consultation process somewhere else.
Okay.
That is, as it goes along, it is a scaled up approach.
Yeah, we saw that with Pink Eye, where people didn't even enter the facility. They were just diverted to another area of the clinic.
So eventually, if you have an outbreak, then you will have to make a makeshift hospital. Maybe you close down a school. Say, okay, this becomes then either your hospital or your hospital.
But you have these places, I think that's what people want to hear, that those places are identified already.
Like
there's
where you
a
have
plan
hurricane
made up
shelters,
that,
if you're
okay,
using
we're
that
at phase
analogy.
4 in the hurricane or epidemic.
Hospitals were asked to identify one or two areas, right? That little book that Nemo has, which has shelters, we went through it on Friday.
Yes.
And that is a scaled up approach, because, as I said, it can either be your school becomes a makeshift hospital, because you are right. I mean, like you have tents maybe, even in the BDF camp, that there's an area that was identified as a potential area to make your makeshift hospital, or whether you take your hospital services to a school, the outpatient setting, you know, while your section, not the hospital itself. So again, that's the reason why NEMO has been alerted, has been kept in the loop. And our meeting at Joint Security Council this afternoon is a means to try to make sure that everybody is aligned and thinking in line with what we are doing.
Okay. Well, what we got to do, we have to take a quick break, and we'll continue the conversation. I want to talk about testing capabilities when we come back, so we'll take a quick break, and we'll be back in a few. Stay tuned.
When someone you love becomes a memory, the memory becomes a treasure. Channel 5 introduces the Daily Obituaries. The Daily Obituaries will broadcast all death and funeral announcements and memorials to honor your loved one's life and memories. The Daily Obituaries airs on Channel 5 prior to the evening newscast, with subsequent repeats at 10 p.m. and 12 noon the following day. It will also be placed online on our social media platforms, all for a standard package fee. Celebrate their lives and memories with Channel 5's Daily Obituaries. Honor in life and reverence in death.
And we're back and we're continuing our conversation with Dr. Marvin Manzanero, the Director of Health Services in the Ministry of Health. If you're just tuning in, we are getting the latest updates and the Ministry of Health's preparation for any potential outbreak of COVID-19. To start off, we still have no confirmed cases at this time, but you've said repeatedly that it's not a matter of if, it's a matter of when for us here in Belize. And we will only know when someone tests positive based on the screening process that you have in place. Do we have the capacity to test for COVID-19 in Belize?
We do. We have primers that were given to us, primers that the reagents used for PCR testing. It's a test that's on a central medical lab. We have had 2 people who went to training in Mexico for the specific technique, and they have come back to do training to staff at central medical lab. If there's any suspect case anywhere in the country, then that person will be swabbed wherever. That sample would be sent as a quasi-emergent situation to central medical lab, and staff would be on standby to process that within 2 or 3 hours.
How many tests have you conducted so far?
Well, again, unless you have an epidemiological link and you're sick, you're going to go through that test.
Yeah.
If you're coming in with the flu, or you're going to go through the usual screening process, which is all the other viruses, because that is the algorithm that all the countries in the region are, even in Mexico, they are not screening anybody unless you have a link or to Europe or any of those countries that have ongoing transmission and have symptoms. That's where you're going to be screened.
But will that change now? Because now we're seeing, even in the United States, where they're saying that it's quite possible that the virus was spreading without them even noticing. I know the FDA had to change their regulations for screening over the weekend as well, because they simply weren't testing enough to be able to catch it.
We may change it this week. This is a changing dynamics, but that doesn't mean you're not going to be screened for the other viruses first. If you are finding out that your patient has adenovirus, influenza A, influenza B, any of those, H1N1, one of our staff had H1N1 10 days ago, was out from work for 3 days, swabbed and has H1N1. Doesn't mean that you're going to be screened for COVID-19 then. I mean, if everything is negative, then that perhaps is the algorithm change that will need to happen.
Is it a resource issue, that it's expensive to screen people?
Not really, but it's not a public health routine measure that you would take.
Okay, so let me understand. What would make you, if I go to Los Angeles right now and I come back, I'm a little fluish, what would make you screen me for COVID-19?
I wouldn't.
Even if I went to LA and there are cases there?
No, because I will have to screen for all the other viruses first.
Okay. So you screen for everything else first, and then if it's none of those, then you screen for COVID-19. How long is this turnaround time?
2 hours for COVID-19,
Okay.
2 to 3 hours.
Let me ask you, Doc. There is no known cure at this point, correct?
No, it's a virus.
It's a virus. Good. So in terms of the treatment then, we have a case in Belize. Good. The individual is identified and is either isolated, kept at home, or what have you. What is done? Is there anything that can be taken? You just wait it out? What happens? I think that's an honest question that other people want to know.
Assume I get COVID-19 right now. I walk out, start having dry cough, whatever. Go and get screened, I'm positive. If I'm not that symptomatic, if I'm not requiring any hospital care, what would I do if I'm the patient? I would go home, take perhaps the Tylenol if I'm having fever, or if again, eat healthy, drink healthy, rest well, keep isolation, make sure you're not contaminating surfaces or spreading it to, not be walking out in the street, of course, or going back to work. I mean, you're trying to contain it yourself. You would not, what we are envisioning is that the healthcare provider would be checking up on the patient at least once or twice a day, either by phone or going to check. And we have been checking physically. That's why I'm saying staff has been trained. For people who are in self-isolation, we go and send a team that checks on you daily. So if I'm the patient, again, if I probably will, a vast amount of the time, I will take care of it on myself. Your body's going to do it on your own.
So if you're healthy enough, then you're saying that the body creates the antibodies to ward off this particular pathogen.
Just like the flu, 2-3 days and you're going to be good to go for the most part.
It's like how some people bounce back differently from the flu. So I may get it and be sick for a week or two, and someone might get it and be better in 3-4 days.
And 80% of the people are not going to have a sign or a symptom. Now, if you do that model, because you're saying screening, but you can't be screening everybody. The Mexican Secretary of State, for example, it's a big population, 125 million people, I think. They are projecting that by 2020, up to 80 million Mexicans would have had COVID-19 in the worst case scenario. And the vast amount of those would never know, would never develop sign or symptoms. So that's the same pattern that other viruses will have. So going back to me being the patient, then after 2 or 3 days, I should no longer be having. Now, if I'm getting progressively ill, I should be alerting the healthcare provider, because then you have to manage it according to what you have.
So you can't catch, my mind is racing here now. So theoretically then, you can contract or catch COVID-19 more than once?
That's what seems to happen in some cases in China. I haven't read the medical explanation why. Because in theory, I mean, the reason why you get the flu every year, is because you have different viruses. Some people never seem to get the flu, but it has to do with your overall health status.
Your immune system.
Your immune system. But there's no treatment. I mean, it's going to, that's why there's...
So you may take like fever medication.
Yeah, the usual things that you would take for the flu.
Is there anything like in dengue that you shouldn't take?
Not that we are aware of. It's common cold and cough medication that you would use.
So what you're saying, Dr. Manzanero, is that people may come into this country, have COVID-19, and never even, because the last week, I think, especially with the cases in the US, what they realized is that people are transmitting when they're asymptomatic, which means they have no symptoms or no visible symptoms of a flu.
Well, that's what happened. I think the last time I was here, Mexico City had just that incident. Somebody came as a tourist, toured Mexico City for 2 days in a city of 24 million people, went back to China, tested positive. No sign or symptom in Mexico. And this, I don't know that they can track how many people this person came in contact with. It's the same thing here. I mean,
and they didn't get a case until now.
And there are all 6 imported cases, no further transmission.
To Italy and
have a link to Italy. The Brazil case is linked to Europe. The Ecuador case linked to Europe. But that person has spread it to 5 other family members. The ones in the French islands linked to Europe, Dominican Republic as well.
And now, but I think what is more concerning for us is the areas of closer proximity, the community spread that seems to have been happening in the United States. Florida now has cases. New York has a case. Los Angeles. These are all areas that we know people in Belize travel to and travel from. So how does that change things for us here?
It becomes much more complicated because it's not, so does that mean that you screen just about everybody coming through the airport? And that's what I'm saying. I think we also need to highlight the fact that routine screening, the way we have been doing, when you look at the science behind it, there is no scientific evidence that says it really works. I mean, you waste resources, and they say waste. That's a scientific term.
You check temperatures when people come in?
No, we are doing this for epidemiological link first, and anyone has flu-like symptoms, but there is a health staff at the airport. For those that are seemingly ill, like we have done at the western border and northern border, we send a health team to go get clearance in terms of your epidemiological link.
You have said part of the information that now comes out is that you're scientists have been kind of looking at what's happening in China. And one of the key things that we do have to keep as a part of the messaging is how serious the illness is or how serious it is not. 80% of those who get COVID-19, who tested positive for COVID-19, 8 out of 10 people fare off fine, no hospitalization required.
Yeah, and a vast amount of unknowns in terms of being asymptomatic that develop no sign or symptom. Those who are progressively ill and who are more likely to get complicated are the older population and those who have a chronic disease. That's what we know, and that follows the same pattern as other flu viruses. There seems to be a higher probability of males dying, and I think it's about 2.8 to 1.7%. That is still unclear why that is happening.
Okay. Now, what is the contagion rate? How contagious is the virus? What do we know so far?
One person can spread it on average to 3.4 persons.
Okay.
Yeah, it's a little bit above the average on the traditional flu, which is about 3. One person passing it on to 3. But it's going, again, containment and all these issues, the fear is really, it's really literally in our hands. Yeah, I mean, it's literally in our hands. We are the ones who are, because people are concerned, okay, what's the Ministry of Health going to do? What's my hospital going to do? But it's really also a community responsibility, a family responsibility, a personal responsibility. We have to take, what am I going to do to prevent the spread or for me getting COVID?
When you look at all the procedures, if I may want of a better word here, that the World Health Organization or PAHO or all these other health organizations would put out there in terms of how to wash your hand properly and what have you. A lot of people would say, well, I don't wash my hand in that grave detail, like, and the 20 minutes or however
20
long,
seconds.
20 seconds or however long it takes to do all of that stuff. How do you, like, because I think people, you go to the restroom or you go into the kitchen, you apply soap, you wash your hands, but I don't know that there's any specific detail being paid attention to in terms of how you go about doing it the proper way.
Well, there's, beyond the 20 seconds, it's also what we tend to do, right? Because sometimes we come out of the bathroom and we have closed after we wash our hands.
Yeah, there's not.
Or we dry it off and then go to the door and take the door handle, so you have defeated the purpose of washing your hands.
Or we use the same towels in bathrooms too.
Yeah, so you're defeating the purpose in that regard. But there's other simple things that we tend to do. In a restaurant, for example, so this is subconsciously, I think, a training. For example, I never really hold a ketchup bottle or any of those things with my bare hand. You always find a napkin, hold it, and those simple things, because you can go to wash your hands before you eat, but then you come back to the table and you take the sugar if you're going to have coffee and whatever, you've really contaminated yourself. I think it's a conscious and consistent and chronic effort that we need to do with hand washing. But
these functions happen subconsciously or unknowingly. Like I would just pick up the tomato paste. I'm not thinking, you know what, that bottle is loaded with germs or whatsoever.
But it's a phone as well. I mean, maybe this is the opportunity then to start shying away from the phone. Maybe shying away from social media in that regard.
Phones are personal though. I don't share my phone.
But it does you're sharing. Everybody else is sharing your germs via your phone.
So we know, and the message has been the same across the board. We need to be more dedicated to hand washing and also sneezing and coughing etiquette. I know one of the things we do a lot of in Belize is reusing a rag when we're sick, which is probably one of the worst practices that we have. Can you explain that?
Yeah, the thing is we tend to leave the rag everywhere around.
I mean, I cough and it put the germs there, set it down, pick it up again, it's there on the table.
And then you're getting other things wherever you're putting it on. But
so you
in terms of
disposable tissue.
Yeah, and dispose of it in
the trash.
In the bin, and then you have the washing of hands, because that's what happens. You see, even if you're sneezing in let's say I sneeze in whatever. I probably don't cover all of my face. That hand goes and touches everything here. That's the mechanism in terms of that. But in terms of hand washing, and I think, again, COVID-19 brings it to the limelight in that regard. 90% of all infections are going to be prevented if you wash your hands and avoid touching your face, right? Because the entry point is usually nose, mouth, and eyes. Not COVID-19, everything else. And it's the same thing that happens inside hospitals. You know, there are now published studies that talk about, in the past, phones didn't make their way into an operating theater, but now they do. And I mean, even when if you culture the hand, because I agree with what you're saying in terms of the consistent hand washing. It happens with healthcare workers. When you swab the hands of healthcare workers who are in touch with, they have more lethal, it's a petri dish, if you will, because we are also not consistent in that regard. So I think that's the mechanism that we need to start to get clear. If we do that consistently, we are going to do a lot in terms of our health and everybody's health.
Doc. Quick question. If you were to give an advice, hand sanitizer versus mask, hand sanitizer is always the better way to go? Like if I keep a hand sanitizer on my desk, would I be okay if I constantly...
You would be far better off. People have asked me, do I have masks? I have none at home. And I don't intend to keep any because of COVID-19 either.
Yeah. Now, I want to tackle two more issues. One is looking at the preparedness of healthcare workers. We've seen in past outbreaks, SARS especially, where healthcare workers are the ones that are most severely affected by outbreaks. What is the preparation that's taking place in the hospitals and clinics across the country? And what's the inclusion of the private institutions? Because oftentimes the private clinics, I don't know if they have the same training as the public institutions.
I know that last week, Friday, one private institution approached Carl Huscher in terms of the persons that are trained there in PPE, how to use personal protective equipment for healthcare workers.
So that's like the big suits
so
that they wear?
that training I think has happened, not necessarily for COVID-19, but for Ebola and those kits. So the Ebola kits that we had and we never used, we are using some of that. So one thing that has happened is we have done a census of how much PPE kits we have each facility. We are going to put that in a central warehouse because we are not going to be giving it out just like that. It's going to go to any place that identifies it and needs it. We have sent that request to PAHO to have a potential list based on the population of healthcare workers. Also, PAHO is not going to be deploying it to every country. It's going to be on demand in that regard.
So we do have some of the suits in country.
We have
when we
PPEs.
didn't get Ebola cases.
They are a little bit different. We have PPE kits everywhere. And we have at the central warehouse, and we have said that's only going to go out now based on identified need. We are not just going to be using it or people taking it home, that kind of thing. Because it has happened. People have started stocking up on masks. We are aware of that. Shouldn't happen. So the census has happened in that regard. Training has happened. I know there's one private institution that has requested a meeting with us because they want to see how they go about creating their isolation unit in terms of that. We are going to have the meeting either later on today or later on in the week.
But shouldn't it be mandatory? I mean, if I get sick, I may go to KHMH or I may go to a private institution. When there is a public health emergency like this, shouldn't it be that the level of care and treatment and testing will be the same at any health institution that I go to in the country?
It should. I mean, once you want to enact public health acts in all phases, I guess you can get them to come in a mandatory kind of fashion, which doesn't necessarily seem to work, because if you have uninterested people showing up anyway, it's not going to go anywhere. I mean, I would rather people come voluntarily, and you can have a bargaining agreement in that regard. But you don't have to go that far. I mean, there's 4 online courses, for example, on COVID-19 that I sent out to every person that I know in the health system, doctors and nurses. Please, I strongly recommend that you go through these, because some of these fears are actually coming from healthcare workers themselves.
Of course.
Or fueled even by healthcare workers themselves. So strongly recommend this as far as I would want to go, because I can't oblige you to take a course and you're not going to learn anything from it. So it also has to do with a self-responsibility from healthcare workers.
Now, what you're explaining is social distancing. It's kind of like if you do get sick, or if there is a cluster, if there is an outbreak or an epidemic, that people kind of keep a distance away from each other, not come out in the public. Is NEMO involved? And I know this sounds very extreme, but we see where even in other countries that canned goods off the shelves. We know masks are one of the things that are disappearing, but people are kind of starting to hoard. What's your recommendation there for people to be prepared, but also to kind of temper the panic?
Hoarding of masks is not recommended. We are aware of one
And price
facility
gouging as well.
3 times as much we were told. We were called last week, but I mean we won't be able to control that. Health won't.
Yeah.
We will
You
report
have
it.
to call Bureau of Standards for
We'll
that.
report it, but that's, I mean, we won't. I mean, we're barely able to keep track of all the rumor surveillance happening. Can't do that. It's not routinely recommended. Again, we are not in that mode. Again, if you do the hurricane flags, then yeah, it's not, we are not there. And even so, the mechanisms that we have discussed with NEMO, okay, you're going to cordon off an area, people won't have access to or from, then you will use, they said, you tell us and we'll take the trucks, the goods, whatever supplies to a given area, if it really comes to that. NEMO is made up of subcommittees, you know, and this particular situation is going to be handled by the public health subcommittee, as if you had a hurricane preparedness. So they will follow based on levels of response that we have established as a Ministry of Health.
What concerns you the most as you look forward? You keep on saying it's not if, it's when.
I think the fear that people are having and the rumors behind it. Unfortunately, I think people within the health system are also not helping. I think some people are just criticizing everything that we seem to be doing. In my view, some people are even looking to see where we will slip and say, see, we told you so. We get all kinds of criticisms that we don't have what other countries have, that we don't have this negative pressure thing. That's a reality outside of Belize. We have to live with the reality we have. Listen to the healthcare providers and understand that if we are going to be successful, we said it with Zika, we said it with Chickpea, it's going to require a community, an all-of-community approach at all levels, from the schools, general public, different agencies, different ministries, religious groups. I know some churches started saying that for the time being, don't be shaking hands, that kind of thing. We can appreciate that. But I think it's being able to listen and have trust in whatever we are going to do as a public health system. We have the best interests of people at hand, and we are not going to shy or deny anything. If there is any case that's coming out, we are going to be the first ones to say so. It is not going to be any particular media house, and it's not going to be social media.
Yeah.
Okay.
That's good.
And what people can do differently as of today to protect themselves, prevent the transmission. If you have an elderly person at home, what should I be mindful of?
Making sure that the person is taking their medications if they are needing medication. If the patient is not going to be required, if the person doesn't require to be out in an open setting where they're more likely to be exposed, then you wouldn't put that person at risk. That's what's being recommended actually everywhere in terms of older folks. I mean, you try to have their own
And we're saying
protective
older
environment.
as in what age?
I mean, the mortality rate is 15% in those older than 80. I mean, that's right there.
Yeah.
But again, chronic conditions. I think the more important thing is ensuring that they have their medication, they're going to their doctors for their regular follow-up, and as healthy as they can be.
Okay. Well, thank you very much for providing the update to us this morning. We appreciate it. And I know that you've been updating the Facebook page for the Ministry of Health so people can look out for additional info there.
That's chaotic, but yeah, we're trying.
All right. We're going to go ahead and take a break. When we come back, we're going to be joined by Ms. Universe Belize, Destiny Arnold, for the latest update from her. We're going to take a break and be back in a few.